Invite Dr. Faisal Kamar to please come on stage.
So good morning and assalamu alaikum. I'm Faisal. I've come from Lahore, and we'll go through some of the evidence. That's what the talk is about. Whether lateral uni is as good as medial. Some of the evidence might be overlapped here because my couple of previous colleagues have already gone through it, but repetition is only good. So I have nothing to disclose. So we need to understand that the incidence of lateral compartmental isolated OA is less than 1% in general population and of the total knee replacements. Even the medial isolated compartment is 10 times more than the lateral. And that in itself puts a bias in most of the evidence that's going to come up. Because no matter what study that is, it's very rarely, apart from one or two, were matched. So there's usually a big numbers in medial compartment, and lateral compartment uni knee replacements numbers are always less. We know the advantages of partial knee replacement, whether it's medial or lateral, it's about the same. So the biomechanics are different, and we need to understand this. The lateral compartment is entirely different to the medial. Its tibial plateau is convex, sits more proximally. There's a bit more femoral rollback, and in a deeper flexion, the lateral side opens up a little bit more. And the pattern of wear, not sure if it makes any difference, is different to the typical medial compartment. So indications. So traditionally, isolated compartment OA, I agree. I think angular deformity less than 10, I think that's probably a bit debatable. You can do them in a bit more, provided that they're correct. Body weight, now, as Umar has touched on it as well, less than 80 kilograms is what's recommended, but there has been evidence, Pennington et al. And Zing showed there is no relation between obesity or weight of the patient and the outcome or survival. Then the contraindication, rheumatoid arthritis, I would agree. I wouldn't probably offer my patients a partial knee replacement. Flexion contracture of more than 15. ACL and or MCL deficiency. As Umar touched, I agree. I think evidence is coming up that isolated ACL injury or deficiency, especially in more than 60 years of patients, is not a contraindication. You just need to put a little less slope, and usually they are okay. If combined with MCL or isolated MCL, I think that's probably a bit too much to offer them a partial knee replacement, whether medial or lateral. Similarly, patellofemoral joint OA, that's been a debate for the last 2 decades. And the Oxford group is very clear on this. They don't think that makes any difference. And to be fair, I would agree, because if patient comes to you and they have got grade 2 or 3 OA, we don't offer them a knee replacement. So when it comes down to offering them a partial knee replacement, it shouldn't really make a difference in the decision. And this has been proved by Berger with 140 cases that radiological OA changes and even malalignment in patellofemoral joint doesn't associate them with poor outcome. So just to touch on alignment, it's not really a topic of my talk, but undercorrection is better, whether it's medial or lateral, to prevent the overstuffing. So just a little bit, 1 or 2 degrees of undercorrection is better, not offloading your axis to the lateral side, because that will lead to OA progression on the contralateral side. Why it's important? Because you'll find out later on that most of the commonest reason, even in mobile bearing, is not polydislocation, cause for revision. It's the OA progression. So same goes for medial or lateral. Slide under correction is better. So we'll look at the data in the last decade or so, and I will try to go through these 3 topics of survivorship, functional outcome, and complication rate between medial and lateral unis. So survivorship, fixed and mobile bearing, Mujahid has just gone through it. Revision rates and mode of failures. So fixed and mobile bearing, a meta-analysis, 17 studies, 2,600 odd patients. Incidence of revision is the same, whether it's the medial or lateral. Dislocation is the early cause of revision in mobile bearing, as previously mentioned as well, and polywear in the fixed bearing. Why do the lateral unis fail? Listed all, looked at it, and it's actually the OA progression in 36%, and half of that is about bearing dislocation. So it's 2:1. It's not the bearing dislocation the commonest cause in lateral uni. And a meta-analysis between direct, median, and lateral, there's no difference in pain score or functional outcome. Short to midterm and even the long-term results are pretty much the same. Long-term is slight difference, but more or less the same. So it's equal. Baker et al. Looked at it, and so this was quite a famous paper and was quoted a lot. And the reason for unexplained pain was just the easy revision. It wasn't necessarily they were able to identify a cause for the revision. It was just easy to revise, as Umar mentioned as well, and that led to a lot of revisions of partial knee replacements, bringing a bad name. So Hazy et al. Looked at UKs in less than 60 years of patients, and there was similar outcome at 10 years between medial and lateral uni. Lombardi and Vanderlist did the systematic review in 2015, but there was slightly better survivorship in lateral uni, but the numbers were not matched. And there was a big cohort of medial compartmental knee replacements and very small numbers, almost, well, 1% of the total were lateral. So just their cohort or the papers that they looked at showed slightly better survivorship. Zing looked at the factors that lead or influence the outcome, and the functional score was exactly the same. Patients were equally happy. There was no difference. And then looking at whether people can, in younger patients, because that's what most people end up having, partial knee replacements, or at least the original concept was. And both these papers show that its comparative results, the ability to return to sporting activity or pre-operation or pre-arthritic symptoms level. So it's over 90% for both of them, medial and lateral. Better quality, Leibs et al. Looked at 558 UKs. Slightly better WOMAC and pain score and SF36 score for medial, but the survival rate was the same between medial and lateral. Different alignment, does that lead to a difference in outcome? 143 medial and 36 lateral uni replacement, and that's what the bias I was talking about. And all the other studies as well, it's just lesser numbers. But functional outcome, forgotten joint score, and I think that's important because I've always noticed that patients who have partial knee replacements, not all of them, but some of them will forget that they've had a knee replacement. Total knee replacements hardly ever get that. Is it because they retain some of the proprioception? Is it a smaller operation? They still have 2/3 of their natural joint? I don't know the reason, but I would agree that you can find patients who've had partial knee replacements and they've forgotten they've had a knee replacement. Doesn't happen with, or really, I haven't seen, I can't even remember in a total knee replacement for that to happen. So analysis of the complications after knee replacements, partial knee replacements, Kim et al. Looked at over 1,500 cases, 89 complications, all of them were in medial uni. No complication in lateral, but out of those 1,576, there are only 26 lateral uni knee replacements in that. So that's the bias that is there. And bearing dislocation was 42 out of the 89. Lateral uni, is it as good as medial? I would think so. I would say that in experienced hands, it is. If you keep your indications the way it's supposed to be, then yes. And my personal criteria is one finger test, which was published in 2005. So if patient comes and point a finger at either the medial or the lateral compartment, say that's where my pain is, and they've got grade 4 arthritis affecting quality of life, I'll offer them knee replacement. But if they come and put a hand on the knee and say it hurts all around, I need to be very sure that they can have a partial knee replacement. I think that's it. Thank you.